Bismillah ar-Rahman ar-Rahim. Assessment of jaundice by Professor Dr. Amr Abdelmati, Hepatobiliary Unit, Department of Internal Medicine. At the end of the 6-year exam, dear students, you will have a medical problem, and we now assess how we go through this medical problem. You will get givens in the personal data, in the present history, in the drug history, okay, then in the clinical examination, then in the laboratory, and in the radiological investigations. You will collect the positive data in each item, then you can reach the differential diagnosis and the diagnosis. Our case today is a case of jaundice. How do we do diagnostic approach? First of all, jaundice is yellowish discoloration of skin and mucous membrane due to elevation of serum bilirubin more than 3 mg per deciliter. It should be distinguished from pseudo-jaundice, in which a patient may have eaten a lot of carrots. This will give him an orange color. This is called pseudo-jaundice due to carotenemia. As I mentioned before, we will start collecting data in the history. What are the important questions you should ask that give you clue to the etiological agent? Of course, the risk, the risk factor leading to the development of jaundice. For example, alcohol abuse, intravenous drug use, occupational history due to exposure for carbon tetrachloride gases, traveler to an endemic area in which there is poor standard of hygiene, and the fecal oral transmission, for example, of hepatitis A. And the sexual activity. You know that several viruses are transmitted sexually, for example, hepatitis B virus. So you should ask of the number of partners, type of the relationship, okay, and if your partner has hepatitis B or not, okay. Also, HIV is one of the sexually transmitted viruses. If you suspect that a patient is drinking alcohol and it is the etiological agent for the underlying liver disease, we have what's called the GAG score. Its importance is to assess the magnitude of alcohol intake. It compromises several questions. You will ask it to the patient. For example, the first question: do you have to take a drink of alcohol in the morning and in the night to get your mood adjusted? This is the first question. If he says yes, it means that he drinks on a daily basis. Second question: have you tried to quit alcohol and you failed? It means that there is strong habituation to alcohol. Third, is there any criticism from the surrounding people to you for alcohol intake? If there is yes, it means that he is drinking alcohol on a daily basis. Second question: if you get a pregnant female with jaundice, you should ask her of the previous pregnancies. Was there jaundice in this previous pregnancies or not? Because if that happens with every pregnancy, it means recurrent intrahepatic cholestasis of pregnancy due to elevation of maternal hormones, which suppresses bilirubin excretion. History of inflammatory bowel disease. I mean that there is patient complaining of frequent diarrhea, more than 15 times per day, with blood and mucus. That means IBD. What's the relation? Yes, there is strong relation between the immune system attacking the colon and now attacking the bile duct, what we call primary sclerosing cholangitis. History of blood transfusion. Of course, when there is blood transfusion, repeated blood transfusion, there is risk of viral transmission, risk of hemocirrhosis and liver affection. If there is a history of inherited blood diseases like hemoglobinopathies, thalassemia, sickle cell disease. Surgical history. If a patient gives you a history that he did cholecystectomy several days ago and now he is jaundiced, the first thing is the probability of surgical ligation of the common bile duct. Now we come to a very important issue in a patient with jaundice. When you take his history, you have to take a detailed drug history. What medications he have taken in the last couple of weeks, and herbal supplementation, okay, because they have strong association with cholestasis. Now, after we took the history, we ask the patient for the complaint. The patient may be completely asymptomatic. We have several cases of liver injuries, for example, Gilbert disease. The patient has a mild jaundice and completely asymptomatic. Or he may present with symptoms specific for the liver disease like fatigue, pruritus, and weight loss. Okay, change in the color of urine and stool, in which there is darkening of urine and lightening in color of stool. Pain. Pain is a very important issue, and it suggests that there is biliary colic, ascending cholangitis. When we start examining the patient with jaundice, you should focus on the liver status. You examine the liver, evaluate it. If there is criteria of liver cirrhosis, enlarged, firm, sharp border, this means a chronic liver disease, and that there is etiology is long-standing. Examination of skin. Of course, in chronic liver disease, you have the signs of chronic hepatocyte dysfunction, in which there is white nails, petechiae, spider nevi, okay, lower limb edema. Patients who are alcohol habituation, they have specific signs in which there is parotid gland enlargement and Dupuytren contracture. Dupuytren contracture. Dupuytren contracture in which there is contracture of the palmar aponeurosis. We should look for the spleen, if it is enlarged or not, okay, because when it is enlarged, it means that this chronic liver disease and there is portal hypertension. Affection of the brain, what's the importance? If this is a chronic liver disease and you have cerebral manifestations, it means that hepatic encephalopathy, and it's a chronic liver disease, or it's an acute liver injury and acute liver failure. Okay, so if you have disturbance of consciousness, confusion, somnolence, astrexis, okay, this is a clue that there is hepatic encephalopathy. The value of examination of the lung and the liver. In the patient with jaundice, if you find pleural effusion, okay, this means that there is a hepatopulmonary syndrome and there is excessive fluid collection. Now we come to a very important point. In a patient with jaundice, if you feel the gallbladder or you don't feel the gallbladder, this is crucial or very important. The presence or absence of a palpable gallbladder should be noted. We have here a very important law called Courvoisier law. It states that enlargement of the gallbladder with jaundice, is likely to result from cancer head pancreas due to gradual obstruction of the tumor to the common bile duct, leading to distension of the gallbladder. So I repeat again. If you have, according to Courvoisier law, if you have a jaundice patient with enlarged gallbladder, it means gradual obstruction by a pancreatic tumor to the common bile duct, leading to distension of the gallbladder. On the contrary, if you have a patient with a stone in the common bile duct, this leads to secondary cholangitis, scarring and contracture of the gallbladder. So pain without palpable gallbladder, it means probably a stone in the common bile duct. So Courvoisier law is very important issue. Now we go to the third box, which is the laboratory investigations. Okay, laboratory investigations. Of course, when you get a patient with jaundice, you should do what we call liver test profile. You assess the liver functions. Assessment of the liver functions, we have two set of labs. Cellular function, which include the ALT, AST, bilirubin, albumin, prothrombin, and the biliary tract enzymes, which are the serum bile acids, alkaline phosphatase, and gamma glutamyl transferase. Okay, so we have, in a case of jaundice, whether it's a hepatocellular pattern or a cholestatic pattern. If we have a liver cell injury, it's called hepatocellular pattern. And if we have bile duct injury, we have a cholestatic pattern. In hepatocellular injury, the hepatocellular enzymes are elevated. In bile duct injury, the bile duct enzymes are elevated. However, there is no sharp demarcation. So in case of hepatocellular injury, you will find the hepatocellular enzymes elevated, but the cholestatic markers are slightly elevated, and vice versa. Okay, so we have two patterns of liver function derangement have been described, cholestatic and the hepatocellular pattern. The cholestatic pattern consists of elevation of bilirubin, alkaline, and gamma GT, and the hepatocellular pattern consists of bilirubin, ALT, and AST. These patterns are non-specific and significantly overlap. Now, I am asking for the etiology of liver injury. I have to go for the etiological agent that led to hepatitis. I will go step by step, screening all the causes leading to jaundice. Autoimmune hepatitis. Autoimmune hepatitis is one of the causes for acute and chronic hepatitis. And in such cases, I ask for the immune markers, which are anti-nuclear antibody, smooth muscle antibody. And in children, we look for liver-kidney microsomal antibody. We have another immune liver disease, which is called IgG cholangiopathy, okay, in which there is inflammation in all tissues, including the salivary glands, subcutaneous tissue, the pancreas, okay, and the bile ducts. It is diagnosed by elevation of the serum IgG4, in which the level is more than 1.35 gram per liter. Now I have also to screen for the viral etiology, which is a very important issue for the cause of hepatitis. I have hepatitis A, B, C, D, and E. Okay. If in the clinical data showed that the patient has thalassaemic features, or I should look for the hemolysis. I ask for lactic dehydrogenase and reticulocytic count. Next, for other causes for liver injury, in case of hemochromatosis, okay, you will ask for the serum iron, transferrin saturation, okay, and a genetic study to determine if there is a mutation in the HFE gene. In case you find that the cholestatic pattern of enzymes in a female, you should think of primary biliary cirrhosis. Primary biliary cirrhosis, in which a female in the middle age complaining of pruritus. And if your cholestatic markers, I mean the gamma GT, alkaline, and bilirubin, bile acids are elevated, okay, you should ask for the immunological diagnostic marker for primary biliary cirrhosis, which is the anti-mitochondrial antibody. And on the other side, if I get cholestatic marker elevation of the cholestatic patterns in a patient with IBD, it means that this patient has primary sclerosing cholangitis. And what is the diagnostic marker is the anti-nuclear cytoplasmic antibody, or the ANCA, okay? We continue for asking for the metabolic liver diseases. Alpha-1 antitrypsin should ask for PCR. Wilson, in which there is a Kaiser-Fleischer ring and elevation of serum copper and total copper concentration in the liver. We have some parasitic diseases that leads to jaundice and cholestasis. For example, the fasciola worm, because the fasciola worm lives in the common bile duct, leading to its obstruction. So if you think of that, you should ask for the fasciola antibody. Other causes for cholestasis and jaundice is the AIDS. AIDS leads to cholangiopathy, okay? So you should test for HIV. Now, we have finished the history taking, the clinical examination, and the laboratory. And in the history we looked for all the causes that leads to jaundice. In the clinical examination, we assess it's an acute liver disease or it's a chronic liver disease in which there is liver cirrhosis and splenomegaly. And in the lab, we asked for all the etiologies that led to this situation. And we stressed on 2 points is the Courvoisier law, in which if there is jaundice, okay, and palpable gallbladder, it means cancer had pancreas, okay, and if there is jaundice without palpable gallbladder, it means stone and scarring of the gallbladder. Now, the first thing in the last item is the radiological examination. Okay, the first step for assessment of patients with jaundice is you have to do an ultrasonography of the liver. Ultrasonography of the liver is very crucial. It will give you idea about the liver status. Is it a chronic liver disease, or is it an acute liver disease? In a chronic liver disease, I mean that liver cirrhosis. The liver is shrunken, irregular, excessive fibrosis, irregular outline, dilated portal vein, and splenomegaly. So you understand you're dealing with acute liver disease or a chronic liver disease. Okay. In case, the second point is the bile ducts. Are the bile ducts inside the liver dilated or not dilated? If the bile ducts are dilated, it means that there is obstruction outside the liver. Okay, for example, stone in the end of the common bile duct. So it will lead to back pressure and dilatation of the bile ducts inside the liver. Okay, so we call it extrahepatic cholestasis. If the ultrasound doesn't show any dilatation of the bile ducts inside the liver, it means intrahepatic cholestasis. Okay, so ultrasound is crucial for differentiation between intrahepatic cholestasis and extrahepatic cholestasis. Now, I have extra hepatic cholestasis, and the patient is not complaining of pain. I have extra hepatic cholestasis, the bile ducts inside the liver are dilated, and a patient is old age, cachectic, and not complaining of pain. Means painless jaundice. Again, painless jaundice, okay, with intrahepatic biliary dilatation. This means cancer had pancreas. What is the radiological modality I will use to diagnose cancer had pancreas? I will use contrast enhanced triphasic CT, okay, or dynamic MRI, or endoscopic ultrasound, evaluation of the pancreas for detection of pancreatic head tumor. On the other side, if I have a patient complaining of jaundice and it is painful, as I mentioned before, painful jaundice, it means a stone in the common bile duct with biliary contraction. In such situation, how can I see the bile ducts? I see the bile ducts by asking for magnetic resonance cholangiopancreatography, so that I can see the bile ducts inside the liver down to its entry into the duodenum. I don't use as a first step for diagnosis ERCP. I use MRCP because MRCP is a non-invasive procedure. So if a patient is complaining of jaundice with biliary colic, it means a stone. How can I see it? I go for MRCP. If the patient has painless jaundice, okay, and the gallbladder is enlarged and there is no pain and there is jaundice with cachexia, I'm suspecting malignancy in the pancreas, I will ask for triphasic CT. So this is how can I go through a case of jaundice. Okay, I have to take proper history, proper clinical examination. I go through the lab checking all the points that leads to hepatitis or cholestasis. Then I will go to the radiology. First step, I go with ultrasound evaluation to see it is intrahepatic cholestasis or extrahepatic. Okay, in case of intrahepatic, it means hepatocellular disease. I go for viral etiology, for example. If there is bile duct injury, it means I have to evaluate. Okay, if I'm thinking of malignancy, how do I think that's malignancy? It's a painless jaundice. Okay, I go for triphasic CT with pancreatic window. If it is painful jaundice, it means it's stone, so I go for MRCP. Thank you very much.